Hello, my name's Mervyn Singer and I'm at University College London in the UK, and it's my great pleasure to talk to you today about sepsis definitions and diagnosis. So what is sepsis? In the good old days, it was defined as such. You had infection, and if you had 2 or 4 of the systemic inflammatory response syndrome, SIRS criteria, that counted as having sepsis. If you had organ dysfunction, not well defined, that was severe sepsis. And if you had severe sepsis with either hypotension and or lactate, that qualified you as having septic shock. However, these were a bit vague and not clearly precisely defined. And the other problem with SIRS, that it's rather non-specific, and this was abandoned in 2016. So these are the 4 SIRS criteria. Unfortunately, you don't need to have sepsis to have some of these features. You can have a bad cold, for example, and you can have a temperature, you can have an accompanying tachycardia and a rise in white count, for example. So this just reflects an appropriate host response to infection rather than one that will progress to potentially kill you. The other problem about SIRS is it's not specific for an infectious inflammatory insult. So, for example, it's commonly seen a day or 2 days after uncomplicated elective major surgery. So it's a marker of inflammation, but it's certainly not specific for infection. And studies have shown that half of all hospital inpatients have at least one episode of SIRS during their hospital stay, and clearly many of them don't actually have an infection. And a big Australian study showed that 1 in 8 admissions to intensive care with multi-organ failure induced by infection were SIRS negative. So there's a risk of missing patients just by using SIRS criteria. So the recent definitions that came out in 2016, the so-called Sepsis 3 definitions, sought to clarify and simplify matters. These have been widely accepted. I looked this up a few days ago, and over 3.6 million people have viewed the article, and it's been cited in 11,000 papers. So it's well and truly out there. And the emphasis has moved perhaps away from the infection towards the host response. So the infection's the trigger, but that in some patients results in a dysregulated host response that in turn causes organ dysfunction that may be life-threatening to that patient. So that's the definition: life-threatening organ dysfunction caused by a dysregulated host response to infection. And the clinical criteria used to characterize this for coding, epidemiology, whatever, is a change of 2 points or more in the SOFA score. I'll talk about that in a second. So we need to remove terminologies like the patient has a septic toe. They have urosepsis, where they might just have dysuria and no other evidence of organ dysfunction. The word septicemia is a rather meaningless term. I don't know, never known what it actually means, so please abandon that use, and just stressing the fact the patient must have new organ dysfunction. So we use the SOFA score. These are currently 6 systems and use criteria that are relatively easily, quickly recorded, either clinically, like the Glasgow Coma score, or with a blood gas, or simple, routinely collected laboratory data like platelets and bilirubin. There are some of the systems that require the addition of interventional support. So clearly, for example, cardiovascular, if you're requiring more vasopressor support, you score more points. And there's a scoring system of 0 to 4 for each of the 6 systems, 0 being normal and 4 being abnormal. So you're looking overall for a change of 2 or more SOFA points related to that acute infection, and that increases the risk of dying by 10% plus. For septic shock, this should be defined as a subset of sepsis in which particularly profound circulatory, cellular and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. So despite adequate volume resuscitation, the blood pressure remains below 65 millimeters of mercury, so vasopressors are needed to elevate it above, and the serum lactate level remains at 2 millimoles per litre or above. So this is not just hypotension on its own, it's not just a high lactate on its own. Studies have shown that the combination after adequate volume replacement gives an approximate mortality, hospital mortality, of about 40 to 50%, as opposed to 25 to 30% if you have sepsis. In terms of diagnosing sepsis, there are multiple challenges. The first question is that organ dysfunction related to an infection? Yes or no? And it can be very difficult to determine early on if the patient actually has an infection. Sepsis can present in an unusual, non-textbook manner. Many non-infectious inflammatory conditions can mimic sepsis. Within that umbrella, sepsis is a syndrome, it's not a specific illness, but within that umbrella there can be many underlying pathogens, bacteria, fungi, viruses, atypical organisms, etc. And the other point to mention is within this syndrome, we're now recognizing different subsets who have different biological signatures. They're variably called phenotypes, subphenotypes, endotypes. And the point here is that perhaps the way we intervene with these patients, for example, with immunomodulating therapies, may vary depending on that subset. So just to expand on diagnosis a little bit more in the last few minutes, yes, the patient may have blindingly obvious sepsis. They've got the classic meningococcal type rash, pyuria, cloudy CSF, a lobar pneumonia. But many patients have not so obvious sepsis, especially early in their presentation. Which one of these 3 patients has an infection? It can be difficult. And there are many sepsis mimics, so non-infectious conditions that appear very similar to sepsis. And the danger there is that you may give antibiotics to patients who don't need it, or on the other hand, by focusing on the patient's got an infection, got sepsis, you may delay the real diagnosis and perhaps undertreat or delay treat that true underlying condition. Just to give you one example of a paper, this is from an emergency department in the United States, and they found that more than 50% of patients, this is in the old severe sepsis, but sepsis nowadays, had negative culture results, and those who were identified as being septic, 18% had a non-infectious mimic. And they gave a whole list of non-infectious mimics: colitis, hypovolemia, drugs, adrenal insufficiency, pancreatitis, diabetic ketoacidosis, etc. And you can add other conditions to that list that can present very similar to the septic patient. So as my last slide, how do you diagnose it? It can be difficult. The patient generally looks unwell, so have a high index of suspicion. Take a good history, carefully examine the patient and look for the rash or any other clear signs of infection. Early blood tests, again, are suggestive but not absolute. The patient may have a high or a low white count. They may have a high inflammatory markers such as C-reactive protein, procalcitonin, but these aren't absolute. They can not be present early on, and also a raised inflammatory marker may be due to a non-infectious condition. Clearly look for other markers of infection in urine, CSF, etc. as indicated, and imaging may also help, be it a chest X-ray, a CT scan, ultrasound, etc. The final point I want to make is beware that a lack of classical features does not exclude infection. Just because the patient doesn't have a high or a low white count, doesn't have a high temperature, doesn't mean that they do not have an underlying infection. And elderly patients with comorbidities, often they have underlying dementia, for example, they often present with vague signs and they may not give a clear history. I think in the future we'll have a lot more rapid point-of-care molecular diagnostics to help us work out if the patient has an infection, what type of infection, bacterial, viral, whatever, and also to look at the host response to see, yes, they are systemically inflamed, and these markers also are indicative of a septic process going on. I will finish there. Hope that's been useful, and thank you very much for listening.